Good morning, everyone. Today, our topic of discussion is facial nerve with vertigo and Meniere's disease. So, first of all, I would like to talk about facial nerve. So, facial nerve, as you know, it is the seventh cranial nerve, and it's a mixed nerve. Mixed means what? Mixed means it have both sensory as well as motor roots. Also, it carries parasympathetic fibers, and in the slide, of course, there is a lot written about facial nerve, but um, what I'm going to discuss is not the two basic things, rather more the clinical side of facial nerve and why we are studying this thing, and what is a concept we must have in case when we are discussing facial nerve. So anyhow, like first of all, I want to, okay, this one is about the nucleus, whatever is there, whatever the nerve is doing, there is always a motor nucleus. In the case of facial nerve, the motor nucleus is in the pons. There of course should be some sensory nucleus and uh, things like this. So now, the important thing to know about this one is sensory nucleus, and then of course because it carries parasympathetic fibers, so they have the parasympathetic nuclei as well. So um, in anatomy, we always study the course of the nerves and the vessels. So this one is like facial nerve have intracranial part and it have extracranial part, though. So the intracranial part can be divided into the supranuclear segment, nuclear segment, and then infranuclear segment. So you can understand this thing by this simple representation of facial nerve. You can see like there is a facial nucleus, there is a solitary tract nucleus, there is a superior salivatory and lacrimal nucleus. So simply the fibers arises, and what they are showing you is the bony part, and you can see like this is the internal acoustic meatus, and the facial nerve, it arises from here with the vestibulocochlear nerve, and this is like the meatal segment, which is the meatal part, and then there is the labyrinthine segment. Now here it gives greater superficial petrosal nerve, which takes the fibers to the lacrimal gland and the palate and the nasal glands. Whereas you will see like that there is a horizontal segment, and right after that it gives a nerve to the stapedius, which is a muscle in the middle ear, and then like all this is mastoid segment. And in this mastoid segment, see, it is also giving a branch to the chorda tympani. So what is this one? The chorda tympani branch, if you will see, like it carries the taste to the anterior two-third of the tongue, as well as to the sublingual and submaxillary glands. And then it comes out through the stylomastoid foramen and it gives branches: the posterior auricular nerve, digastric nerve, stylohyoid nerve, and then it passes through the parotid gland and gives two more divisions. So the extracranial part, which they are showing over here, is just this one when it comes out of the stylomastoid foramen. Whereas this one uh, is of course the intracranial one, and this all segment which they are showing here is intratemporal segment. So simply uh, how uh, facial nerve gives different branches. Okay, now you can see over here the greater petrosal nerve or the greater superficial petrosal nerve. So this one arises from the uh, geniculate ganglion, right? So this one carries the fibers, the secretomotor fibers to the lacrimal and the nasal glands. Whereas nerve to the stapedius, it's very clear it will supply the stapedius nerve. Then there is Quadrat Mpany, which is like all these branches I'm talking about, of course, like which they are giving in the bony part. And the Quadrat Mpany, what is happening, like as soon as it leaves, um, you can see over here, it is carrying the taste fibers from the anterior two-thirds of the tongue, as well as the fibers to the submaxillary and submandibular glands. Now, you can see over here another representation of the nerve. Simply, you can see like these are the parasympathetic fibers, and the same things which you have seen over here, you can see here as well. This is the submandibular ganglion, this is the pterygopalatine ganglion, and the fibers are going towards the lacrimal gland, towards the nasal mucosa, towards the submandibular and submental salivary glands. Okay, so now if you will see over here, uh, um, these are the specific visual sensations, like the sensations which are carried from the anterior two-third of the tongue, and they are carried here. They are representing the styloid foramen, and this one is internal acoustic meatus, and of course like the nucleus which is in the brain. So like this is just to give you an idea, because the facial nerve have special visual efferents, efferents, sorry, special visual efferents. So simply, special visual efferents are basically that all the, what you can say, the part of the nerve or the motor root of the nerve which is supplying all the muscles of the facial expression. Then there is general visual efferent. So general visual efferent you can see over here. Okay, uh, general visual efferents. So this one. Okay, so they are supplying to the glands. And then there is special visceral afferents, like this one is carrying sensations. And then there is general somatic afferents, facial nerve also carries sensation from the posterior superior part of the external auditory canal and the tympanic membrane. So they are the one which is called as the general somatic afferents. So anyhow, to show you some more representation, I like one of the diagram which is very, very, very good. Like you can say this is the uh, best, you can say, uh, diagram which I can get of facial nerve. Why? You can see they have divided the facial nerve into the supranuclear part, like before the nucleus. So of course, like the nucleus are in the bone. So before that and until the cerebral cortex, this is the supranuclear part, and then there is the nuclear part, which like the nucleus are in the pons. Remember, facial nerve arises from the pons, so they are coming out from there. Okay, and then there is infranuclear cerebropontine angle. Simply, when the nerve arises from the pons and until it is going to enter into the bony part, And as I show you in the previous picture, like there is the eighth and the seventh nerve, they they go together, right? So this is the infranuclear portion, and then there is the internal auditory canal portion they are showing over here, where see. Uh, the eighth nerve is supplying the vestibule and the cochlea. Okay, um, and the seventh nerve is passing. And then, as I show you in the previous photograph, that there is the geniculate ganglion. So this is the geniculate ganglion, and it is going the fibers to the lacrimal glands. And then there is tympanomastoid part, where there it is giving chorda tympani, and see it is supplying the stapedius. Okay, and simply this chorda tympani is the one which is supplying to the sensations to the tongue. Okay, as well as submandibular and sublingual salivary glands. And then there is the extracranial portion which is supplying all the muscles of facial expression. So very nice, and see why it is good, because now whenever there is any pathology over here before the nuclei, we call it as upper motor neuron type of lesion, right? So remember upper motor neuron type of lesion, which is some pathology inside the brain or the tract up till the nucleus. So Of course, in that case, we will go for CT scan, neurological examination as well as MRI. But if you'll come over here, like something which happens like once it enters into the bony canal. So if there is any problem, so what we can do again, we can do CT scan or audiological testing. Uh, if there is any problem with the supply, uh, what you can say, supply the lacrimal glands and all this. So uh, you can see we can do tear test. So tear test is something in which like they check like either you can produce any tears or not, right? And then there is the tympanomastoid part, which is supplying the stapedius and tongue and the uh, salivary glands, you can say the sublingual and submandibular. So we can do the stapedial reflex test, we can check the taste sensations, we can check the salivation, like either the person is producing any saliva or not. And whenever like we are testing the extracranial part, what we can do is like the facial movement, right? So again, like uh, you can see over here, um, like a very nice, you can say, representation about what can be the thing and what tests we can do, right? Now, guys, like I remember the nerve can get injured after coming out from the CNS. It can get injured anywhere, and the degree of nerve injury, like it usually determine like either it is going to regenerate or not. So for that, of course, you have to go and read a lot of basic stuff because sometimes there is injury to the nerve, sometimes there is injury to the axon, and sometimes there could be a conduction block. We call it as neuropraxia. So anyhow, I already talked about nerve conduction studies. Uh, in diagnostic playlist, you can find that one. Um, the point here, which I wanted to put in your mind, is like as I told you, we are going to discuss more clinical part of this thing. Okay, it looks very 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 you can say um, complicated, though it's not complicated because this slide, I make the slide by taking the best photographs which I could found or which I found easy to understand facial nerve. You can see over here, mm, here they are showing the posterior cranial fossa. um, Here they are showing the nuclei. Okay, like this nuclei, there is a nuclei over here, there is a nucleus this one, and there is a nucleus this one. Remember, like the facial nerve carries four type of fibers, so you can count over here, right? Here they are showing five. I will tell you why. Now, uh, this is the internal acoustic meatus, right? And this is the facial canal they have drawn, and this is the stylomastoid foramen. So whatever I show you, uh, either here, okay, or either here, uh, the same thing is shown over here as well. You can see over here, see this one is the submandibular gland, right? uh, the nerve to the submandibular gland and the sublingual one, right? So remember it's blue. So if you will track it back all the way back, you'll find like there's a blue hair as well, which is applying to the nasal mucosa as well as to the lacrimal gland. So track it back, track it back, track it back, and where you will reach this nuclei. On the other hand, if you will go, for example, this is carrying the taste sensation from the anterior two-third of the tongue. Track it back, and where you will go, you will be going somewhere over here. So this is carrying the special sensation, right? So now one more thing, for example, this is the facial expression one, which gives like all the branches after coming from the stylar foramen. And if you will go and track this color back all the way back, see, you will reach to the motor nuclei, right? And what is left, like this one is done, this one is done. Okay, you can see like this one black one, okay, which is a posterior auricular nerve, and track it back, it will go back towards the sensation. Why? Because there's a nerve which is getting the sensation as well. So anyhow, this is how it represent, right? And you can see this is the nerve they are showing, and see Uh, this is like just to explain. You see, the facial nerve exits the posterior cranial fossa and the internal acoustic meatus. Then here they are showing you within the internal acoustic meatus, the facial nerve enters the facial canal. Okay, here they are showing you the first branch of the facial nerve. Okay, the greater petrosal nerve, which I show you in the previous one as well, and it will go to the geniculate ganglion, of course, right here. And so the same representation, there is nothing different. And here they are showing you again the second branch of the facial nerve, which is the stapedial nerve, which it gives within the pony canal, within the ear, middle ear. And then they are showing you the third branch of the facial nerve, okay, the Quadrat Mpany, which is supplying the tongue as well as the submandibular and sublingual glands. And the last one they will show you, of course, the after coming out, it is giving the muscles of facial expression. So now, if you'll combine these four things, brachial motor, visceral motor, special sensory, or general sensory, you can see like this is the combination of four. So that's what I show you before as well. Okay, guys. So this one quite easy to understand, and this is like again a more representation about of the same thing: geniculate ganglion, stapedius muscle. So there is no difference, right? Just the way of drawing this one is different. Okay, now the most important concept, guys. See, this is the most important concept I always say to understand about the facial nerve. If you will see, these are basically upper motor neuron fibers, okay? And these are basically the lower motor neuron fibers, right? Okay. Now, guys, look. See, this is how facial nerve innervate. Okay, just to make you understand, what I will do is, see, the lower half of the face is supplied by the green fibers. Okay, of course, like they're not green in real, but rather they are just drawing it to give you a concept. The expressions from the facial nerve, which are carried by the facial nerve in the lower half, see, track the green one, track it all the way, it goes up till pons, ipsilaterally, and then once it enters the CNS, it cross over and goes to the opposite side. So what it means, the facial expression of the lower half of your right side is controlled by the left side of your cerebral hemisphere. Very easy, right? Contralateral, contralaterally innervated. Whereas if you will follow the upper half of the facial expressions, the facial nerve will carry the was carrying the fibers, and see here, go back as soon as it enters the pons. Now it goes to the contralateral side as well as it gives fibers to the ipsilateral side, which means the upper half of the face is controlled by both of the hemispheres. Now, guys, see, whenever there is a lower motor neuron type of lesion of the facial nerve, we call that thing as Bell's palsy. For example, the facial nerve has damaged over here. What will happen? All the things which are carried from this nerve are gone, upper as well as lower. But come here now. Whenever there is a upper motor neuron type of lesion, like stroke of the left side, see, now the green is completely gone, so the person will be having paralysis over here. The red is also gone, but this side is also getting innervation from the other side. So remember that these muscles will still be working because this one is getting bilateral innervation. If you can understand this thing, your problem is solved. This is what I wanted to tell you. For example, now I will tell you there are many, many, many causes of facial paralysis. Okay, there are many, many, many causes of facial paralysis. Look at this one. She's the one who have facial paralysis. Okay, so now see, this is a female, and she have a facial nerve palsy on the right. Okay, so patient is trying to retract angles of both mouths. See here, the muscles are not working, but here they are working, right? See here, the creases are there, but here there is no creases. Patient is attempting to elevate both eyelids. She can elevate this one, but she cannot elevate this one. So what it means, her upper as well as her lower fibers both are gone. This is a lower motor neuron type of lesion. This is what happens in Bell's palsy. Okay, see guys, now for example, if she just have lower motor is gone but upper is still there, so it means she have upper motor neuron or a central type of problem. For example, what could be the causes of central? Like, there could be a brain abscess, there could be a tumor, there could be stroke, there could be multiple sclerosis. Okay, all these things can occur here. Stroke, tumor, all these things can occur. But here a lot of things can occur. Whenever it is idiopathic, whenever we cannot found any cause of the lower motor neuron type of lesion in facial nerve, we call it as Bell's palsy. Remember, idiopathic lower motor neuron type of lesion of facial nerve is called as Bell's palsy. Otherwise, facial nerve can get damaged at multiple parts. For example, there could be in otitis media, facial nerve can get damaged. Okay, in mastoidectomy, stapedectomy, okay, in tumor of the eighth cranial nerve can compress the facial nerve. Some systemic things like diabetes and all this stuff can damage the facial nerve. So anyhow, this is the most important concept that I wanted to tell you. If you can remember this, the thing will be easy for you. So clinical correlation lesions of the facial nerve, same thing, no difference. What are the things we can check? We can check the flaccid paralysis of the facial muscle of facial expression, upper and lower face. Remember to check both. Loss of corneal blink. Remember that whenever we touch the cornea, the sensation is carried by the fifth nerve, but when we blink, it is the seventh nerve. Loss of taste, hyperacusis when the stapedius paralysis is there, or Bell's palsy, right? Now, what is Bell's phenomena? What is Bell's phenomena like? When someone is trying to close the eyes, the affected eye looks up and out. I will show you over here what is Bell's phenomena. Okay. So, okay. See, this one, very, very, very nice. A person, when we ask them to close the lid, so this one he closed, but this lid, because it cannot be closed, so see the eyes looking up. This thing, or for example, when you ask someone to look up, okay, what will happen? That, see, this one, his eyes goes up. This is called as Bell's phenomena, right? Very, very, very easy, and very, very, very easy concept, right? I will send you this slide. You can go through that. I don't think so. This one is difficult at all. Okay. Again, the same thing which I was showing you. Okay, and they're showing you like lower motor neuron lesion and upper motor neuron lesion. So see, in lower one, both like all the faces affected, but upper one, remember. Okay, very easy to remember. In upper motor neuron type of lesion, there is upper sparing. In upper motor neuron type of lesion, there is upper sparing. So very easy to remember, right? So this thing. Okay, so anyhow, guys, like this is what happens in facial and palsy. These are all the tests which we can do, and you can go through the slide. You can check. Okay, and the things are easy. They are not difficult, right? The slide is very, very, very extensive. Very, very, very extensive. You can see a lot of things. Extracranial injury can be there, temporal bone fracture can be there, and non-traumatic there could be frontal branch function affected or frontal branch function intact. Of course, it will show supranuclear lesion. So like how we go through. So anyhow, this is about facial nerve. I'm telling you, like, the slide is quite extensive. You can go through that, and you can you will know, like, what I wanted to convey. Thank you so much, guys.